Hello, and welcome back to Designing Care on Air. This is Elizabeth Johnson from Montana State University College of Nursing. In today's episode, we're going to explore diversity and inclusiveness in design. When we think about those terms, a lot of times we think about different policies, different training and education, but it also comes back to our space. How are we giving back agency, autonomy, control, and decision-making to those that otherwise may not have a voice? How do we not only make a space at the table, but drag that seat across the room, make it as loud and clear as possible to include these additional voices? One of those change champions is Marjorie Serrano, who is an owner, architect, and clinical planner for health environment innovations in the Dallas-Fort Worth area. Marjorie, thanks for joining us today.
Thank you for having me. It's a pleasure.
So to kick off, do you mind describing for our audience the background, your education, and your current role within the healthcare and facility design industry?
As a child, I wanted to be two things. I wanted to be a nurse and I wanted to be an architect. I didn't know a single architect. I knew a couple of nurses, and that was the 70s. Everyone encouraged a girl to become a nurse. No one encouraged a woman to become an architect. Had I been a couple of years older, I probably would have charged into the architecture world, determined to change that. But at 16, 17, when I was having to make the decision, I wasn't that brave. I went to Baylor University for a Bachelor of Science in Nursing. And at the time, I didn't know that the Baylor architecture program had the 2 years of basics in Waco, which the nursing program did as well. And then the nursing program was 2 years of nursing in Dallas, which was familiar territory to me. I grew up near Austin, but my family had family in Dallas, and I'd been here quite often. The architecture program had the second 2 years in St. Louis, Missouri at George Washington University. And at the time, I didn't know that was such a great architecture program. And St. Louis sounded like a foreign country to me. I would not have been able to go home very often. So I chose nursing basically because of the location more so than the reason that everybody encouraged me into nursing. I was never sorry that I chose nursing. It was a great career. But after 25 years, I needed to go back and get my master's. I'd gone to a certificate program to become a pediatric nurse practitioner, but I needed my master's and wanted that. And I discovered that instead of studying what I've been doing for 25 years, I could do something totally different, which was architecture. I found a program at the University of Texas at Arlington, which is between Dallas and Fort Worth, so it was not too far drive for me. And it was for people with a bachelor's in another field. It was wonderful to go to school with people half my age and to enjoy feeling like a young person again. I generally don't like academia. I don't like going to school, but going to architecture school was just a complete pleasure. I loved it.
That's amazing. And so when you were in architecture school, and to back up a bit, the audience to really know that you have a nursing background, you were an advanced practice nurse. So knowing that background, you're going through architecture school. How did that inform your progress through that program? It's a huge shift. And how does it inform your role now?
Well, not necessarily my nursing background, but just maturity, I felt like helped me a great deal in the program. It was a challenge sometimes when I had professors who were also half my age and kind of unsure of themselves, new in the field. And I'd ask a question like, describe for us they asked the class, do you have any questions? A new professor. And I just raised my hand in the back of the room and said, can you tell me about your background? And he took offense just horribly, I think, because he was embarrassed to say that he had little experience. And from then on, we kind of clashed a bit. But I had a studio with him, and it turned out to be one of the best classes I ever had. And one piece of advice that he gave me that because I needed to pass the course, I didn't argue the point, but I would say to every student to listen to this, that his advice was that a professional needed to work all the time. You didn't have opportunity for breaks. And I knew, having been a professional for over 25 years, that that was exactly opposite from the truth. You need a break every hour, every day, every week, every year. You need to schedule breaks for yourself, especially in architecture, because it can be so intense and such extensive hours. And you have to make time for yourself and for your family. Our life just doesn't work.
Absolutely. And when I think about when we're thinking about teams, where you have the nurses working with the design, you've got engineering, architect teams, meshing all those work cultures can be very challenging. Even the types of communication patterns, our goals, our perspectives. In the role you're taking now, how do you engage with team members? And how do you have clinical nurse voice from those organizations? How do you bring that forth, the end users?
I try to teach. In fact, a great deal of my work is not design, but teaching both sides to learn to speak to each other, both the clinical side learning design speak and the design side learning clinical speak. It amazes me how much healthcare designers and engineers understand about healthcare, but unless they have a spouse or really, really close friend who's in healthcare, or unless they've been involved with it themselves as a provider in some way, they just don't get it. Nursing and providing any type of healthcare is just totally exhausting in every way. Physically, mentally, emotionally, spiritually, it's just completely exhausting. There are many different types of jobs, particularly nursing, so many different directions you can go, but you're always under pressure in the sense that someone's life or health depends on what you do. And that's a constant pressure that nurses are not good at recognizing in themselves. If you're in a very intense area, like in an emergency room or an intensive care unit, you recognize that a little bit more, but not enough. And we need to learn to take care of ourselves. And if you're coming from the design or engineering side, you need to recognize that the people that you're working with are exhausted and they may not even realize themselves that there are things they can do in the design of a facility or in the operations that would make their life much easier and make everything better for the patient.
That's a great point. And I think one of the things I see among nurses is that they're so exhausted, so burnt out, and they have so many other life at stake priorities in front of them that they don't think about the built environment or what the building can do for them, or what design would actually mean as an intersection of their role, rather than mutually exclusive. So, what are your thoughts of how to convey that or bring awareness to nurses about how built environment affects them so that they can talk to architects or engineers?
When it comes to the actual design of the facility, I don't think there's anything more effective than a mock-up, a physical mock-up. There is some value to doing that in a technical environment with VR, but it works for some people and not for others. Actually building a mock-up, whether it starts out as just a space with equipment and building out from there, building cardboard walls, eventually building out every single detail of a room that's going to be repeated, or a room that's very intense, such as an operating room. It's very, very important. And there's nothing that really replaces that in my mind and in my experience. To walk through the space, to do mock events, to imagine yourself in the space. It's not the same as actually using it, but it's a very good substitute for just paper and plans and even 3D renditions of a space is not understandable to everyone.
Yeah, so kind of using a mock-up tool for communication as well, right? So if we can't understand our lexicon between two teams, there's a way to visually communicate.
Right. And a way for the nurses to try out a space and recognize, well, maybe the way we've been doing it for all these years is not what we want. My focus and what I would do full time if I possibly could is to work on the front end before even thinking about whether or not you need to build a new facility or redesign it, before thinking about actually building a new building or space, is to look at how you're working now, how effective is that, and how do you want to work in the future. So doing a lean approach or doing a current workflow, future workflow is very valuable.
And that's one thing I've seen with our students is the value stream mapping, those type of process maps, the review of effectiveness and efficiency in the workflow. This seems to really open up their eyes to what's going on at the system level. Are there other tools that you'd recommend to kind of understand that bird's eye view as a nurse? It's really hard, at least what I've seen, to de-silo ourselves from our departments or our units.
It is. And I think the makeup of your teams helps that dramatically. And the ability to lead a team, a user group, or any type of group, to make sure that everybody in the room has a voice. And even before that, making sure that you have the people in the room that need to be involved. Unfortunately, from the design side, you often don't have a choice about who is in the user group. But what I've done, and is sometimes very effective and sometimes not, is to make a list of who should be in the room. And it should always include current frontline users. So many times it includes managers with experience in their particular field, but that have not worked at the bedside or directly with patients for many, many years. And we know that healthcare changes every minute of every day. And even someone who did it a year ago may be behind the times as far as what's happening today. And especially in the last couple of years, of course, we've had huge changes in the pressure and the way we work. And that is just invaluable. You need to be sure that if you cannot get the people at the table who need to be there, that are on the front line, then at least you need to come up with a way to meet with those people, whether it's just doing Gimbo walks. That I really feel like you should insist on that as a designer, that you can't do your job until you've talked to the people in the front line and observed very closely what they do. Ideally, that should include all shifts, especially night shift, because we tend to think that everything happens Monday through Friday, 8 to 5, and that's not at all true in healthcare. And managers, the further up they are in the chain of command, the more they think that way, because they're not there on the weekend, they're not there at night. They don't recognize the very different problems that happen.
We're seeing new problems, right? We're coming through the dust settling from the acute phase of the pandemic, and this constant change, even with the staff we have, the travel nursing, the turnover and the workforce at a rapid pace. I'm seeing a lot of design work that surrounds inclusion of technology as a way to mitigate that change, which includes the differences between day and night shift, weekend work, kind of using technology as the great equalizer, but that has personally given me some pause. I wanted to hear your thoughts as well about how technology is being incorporated into design and the communication process throughout the design.
Well, it's a challenge because, particularly in the nursing, but also in other healthcare specialties, you always hear about how the workforce is aging. I think the average age of the nurse now is 52, and that's been true for a very long time. And so just the idea of having to do your work on a computer as opposed to paper, like you've done it for however many years you worked when you're 52, 20-something years at least, is very overwhelming and difficult. We depend very much on the younger people who have lived with technology from the time they were born. That's not to say that you should assume because someone's older that they don't get it, because I've actually worked in some facilities. One particular was a community hospital outside of the Dallas area where the population is mostly people over 65. And they were by far the quickest to accept technology, such as talking to your specialist on a robot as opposed to in person or even on the phone to do their calls or do their visits from home. And this was several years before it became popular. So don't assume because the population is older, whether it's patients or staff, that they're not going to take to technology because they may be more expert than you are. However, that bleeds over, I guess, into the design world as well, because the idea of design and making these decisions is, for most people, it's the first time they've ever done that in their career and first time they've ever experienced it, unless maybe they had something to do with building a new home, which is quite different, of course, than a healthcare facility. And the ability to understand a plan, the ability to use the technology is just somewhat overwhelming.
Right. And we definitely echo that overwhelmingly in rural spaces where a lot of our hospitals are still on paper-based charting or really not so much integration. So when we look at rural design, how does even setting budget constraints, cultural considerations, how does that affect your approach at even just beginning a project?
Well, I think, first of all, the most important thing to understand is in a rural area or smaller hospital, everyone needs to be a specialist in everything. They have to be so flexible. It's really easy in a very large facility to say, you have this complicated problem. We're sending you to this special appointment, or we're sending you to a different area of the hospital where they specialize in that. And you can focus on your one area, which might be labor and delivery or psychiatry or something like that. In a small facility, that's just not possible. You have to know a bit about everything. And of course, you cannot know everything about everything. No one can. But you do need to have resources. And I think technology really helps in that respect. You can have resources in the room virtually. And I'm hopeful that every rural facility will begin to incorporate that just as a routine.
Well, and do you have any thoughts about when the budget is really constrained? I mean, that's something else that we've seen too when we're talking about rural. There's really not a lot of funding available, or just looking at renovation work, redesign, clinic rooms, for example. How can we still achieve really great design, even with a budget constraint? What are some tips and tricks that you use?
Well, one of the things I do is to try to start every group, not assume that even the design team understands design thinking, which is not something I was taught in school. And it's not something that as far as I know, is taught in very many schools of design. And I use the techniques that IDEO uses. I think it's a great resource, and you don't have to pay a large amount for the courses. It's wonderful if you can go to their courses, and I'd love to do that myself. But what I've done is read a great deal, done a lot online. Another resource is Game Storming, which is a fabulous book and website that teaches ways to do versions of brainstorming, but they're games that have guidelines, and it's amazing how they can work with all kinds of groups. And I also teach people, and don't assume that every designer, architect, or engineer knows how to draw, to be able to sketch real quickly things, to sketch your ideas as opposed to write the words. I don't know how I would live without Post-its. We use that in the workflows and all types of things. but I've worked with groups who had all types of backgrounds and did a very quick review of how to sketch quickly. I have some resources that I can share with you later, a list of really great resources for that. And to be able to quickly sketch an idea as opposed to write it out is just life-changing in that it's a better way to communicate. All of us are much more visual than we think we are, and we learn that way and we express ourselves better that way. Everybody, when they were 5 years old, knew how to draw. And if you think you can't do it now, you just forgot. You can draw like a 5-year-old. And that's what I encourage people to do. And it's wonderful to see a group just open up with ideas because they start sketching what you're asking or the idea they're trying to impart rather than writing out the words. Not to say that you can't use words too, but using simple pictures is fabulous.
And you touched on something that I really love too, and the visual part that helps nurses get out of their comfort zone and dream big a bit. I think we're always used to asking what we minimum bar on the floor need, but not really dreaming about what design could be.
And I meant to say when you first asked that with every project, no matter how tiny the budget, I try to start with that dream blue sky version. If you could have anything you wanted in the world, the budget was not a constraint, how would your space work or whatever it is that we're trying to decide? How would your workflow go? And start from there and then work down to what's possible. Unless you've really opened your eyes and dreamed big in the beginning, you're just going to create more of what you have. And apparently that's not working very well, or you wouldn't be ready to design something or redesign something new.
And since we're talking about the new side of things, what are some emerging or up-and-coming trends that you're excited about in the healthcare design industry?
One in particular is diversity, inclusion, looking directly at racism specifically, looking at white privilege that we all need to recognize. If you're not a person of color, you cannot possibly, a great deal of what I teach in my sessions and a great deal of the work of IDEO is looking at empathy and really putting yourself in another person's shoes. And you can't totally do that, but you can recognize that in this country, we were not taught true history. We have a great deal of learning to do. And I never imagined myself as a racist. I was raised in a small town where kids of all colors and ethnicities and religions were my friends. They were in my house. They were welcomed by my parents. But I recognize now that the history we were taught was so incomplete. And it's my personal responsibility to go out and learn what I don't know. It's not another person's color's responsibility to teach me that. It's my own responsibility. And I think doing that, we will change how we work and how we think and how we include everyone that needs to be at the table.
I love that. And I'm also very passionate about having this belonging, the sense of openness, the sense of presence to your healthcare facility, to the community spaces. Because a lot of times these clinics, these practices, these hospitals, they're a part of the community. You work there as a community member, you access care there. So how do we help foster belonging, rid ourselves of that otherness, that divergence? For example, in tribal health or helping persons of color feel more included in their healthcare spaces, what can we do on the design end to help that along?
I think, as we've been talking about, including the right people at the table, and first of all, in healthcare, particularly in tertiary care, in the larger hospital facilities where you're treating acute illness, there's a book called Patients Come Second. It was written by administrators at a hospital here in Dallas. And you need to recognize that if you design for the workforce, to make their job easier in the process you're designing for patients. That's especially true of nurses and anyone that's at the front lines. They understand what they need. If you help them to open up, they understand what they need personally to do their job, and that's what helps the patient. But it's also important to include the patient's voice or the community voice about what they want. And so these techniques of having a group draw their ideas, open up and discuss them, share them in a group is very important. And I think every group that begins to design, especially a new facility in a community, they intend to include the community, but it's a difficult thing to do. It's difficult to get the right people at the table, just as it is with designers and healthcare workers. But you can do it. And whether it's on a small or large scale, you must do it if you're going to truly empathize and understand what they need. It's always amazing to me that when you have a group of people, even a group of people that work together all the time, lowest man on the totem pole is the one that comes up with the most amazing ideas that no one else thought of. Even those people whose job description is innovation have never even thought of the things that perhaps the housekeeping worker that has done this job for so many years, or someone that's brand new that comes in with new ideas and is young. Those people need to have a voice, and in the community as well.
And I think that's something that we really need to focus on for those of us who are in higher education with nursing, architecture, engineering, that it's not only just to recognize what everybody can bring and contribute, but it's about empowerment. It's about empowering our nurses, our community members to be incorporated, not already putting that ceiling on yourself, creating your own ceiling if you'd agree, not saying, I don't know enough about a part of this process, I shouldn't raise my hand. I hear that a lot. What do you think about this paradigm shift that I think we need to start working on?
Mm-hmm. It is. And I think especially with new, on both sides, but especially with new designers and engineers, when you go into a group, even when you've had a great deal of experience, especially when you've had a great deal of experience, you need to be sure that the terms you use, avoid initials or abbreviated versions of words, because a word that you commonly use may mean one thing in one facility with one user group, may mean something totally different to another group. Never, ever hesitate, whether you're experienced or it's your first project, to say, I don't understand that, or describe for me what you mean by this. Don't feel like you will sound dumb, that you should not raise your hand or ask the question, because more than likely, there are many people in the room who have the same question and are afraid to ask it. In fact, it's just the reverse. By assuming you know what you're talking about and just going on with it, you will probably create a lot of confusion in your own mind and in someone else's. And you may be designing something that's totally different than what you want.
I agree. And I think it's also asking questions. I see it as a sign of respect. Coming into your facility and your culture, your organization, saying, I acknowledge that I may not know what's going on. So I'm going to ask really clear questions to clarify my worldview so that I'm aligning with you.
That's wonderful. I agree with that completely. Also, I tell people, even if it's a specialty that I've worked in myself for a number of years, for example, in nursing, I spent almost my entire career working with mothers and babies and young children. And so when I go into a space that's being designed for them, I recognize a lot of the challenges and a lot of the issues, but I stress to every group, first thing, I am not the expert on your facility or your work group. You are. And I'm here to learn from you.
And I think that's a big thing too, learning from one another in order to get to that goal. On that note, Do you have any other pieces of advice or words of wisdom that you'd give our nursing, engineering students listening in who are studying systems thinking as well as design? Do you have any advice as they're learning design, learning how to evaluate, understand a system for the first time? What can help them as their students, they're moving on, graduating into the world as professionals, and they're taking on their own projects?
Let me make sure I'm, let's do an example of clarifying what you mean. Make sure I think of systems thinking the same as you do. Can you give me a brief description of that?
Absolutely. De-siloing your thought process, that your worldview or what you perceive is not the only way. We talk about in my class a lot that with systems, you can zoom out to the really large perspective of the U.S. healthcare system. But you need to be agile enough to then zoom in to your department, your shift with agility. Think between those system levels and how it may affect your delivery of care. That's something that we can work on together with all voices incorporated with nursing, engineering, architecture, interior design, all these different professions and people, and the very, very small moments that can lead up to or make up that care delivery.
I would say asking a lot of questions, as we were discussing before, not assuming that you're the expert, even on your particular side of the field, whether it is, organizing these drawings or coming up with a written description of what this group is telling you. Whatever your role is, it's very important, and you need to speak up and ask questions and be sure that you're going the direction that's needed. And that's all through the process. I think it's most dangerous when you become experienced and think you know what you're talking about. And it's thinking of yourself as an expert is dangerous because you're not. We're always learning. We should always be learning. And every group that you work with, every project that you work on should be a fresh new approach. It will keep it interesting for you. And of course, your experience will be helpful, but it's not the answer to everything. I believe one of the biggest mistakes we make in architecture, and I don't know if this is true in engineering as well, but because we've done something like this before, we're always designing another variation of what we've already done. And if we had the right answers, we wouldn't need to design something new. Every facility is different, every situation is different, and in every time period it's different. And so starting with a fresh approach will both make it enjoyable and also much more effective. When you work on even a small building, if it's a new building, it's a long process. And during the time it took from beginning to end of that process, things have changed. And what you're designing is for yesterday, always. And so recognizing that and designing as flexible as possible, but also just keeping in mind that there's probably a better way to do this. From that respect, the thing that I think is most important and is done very little right now in the design world is to go back and do post-occupancy evaluations based on the function of the space. Most design firms say, well, the owner didn't want to pay for that. Well, the owner shouldn't pay for that. They're not the one that benefits very much from your review of what you built or what you've redesigned. The one that benefits is yourself and your own firm, so that next time you can do it better. And if we're not going back 6 months to a year or more after they've moved into a space and been using it, then we don't know whether the space worked or not. We don't know if it's a good idea to repeat those ideas and those designs. And yet we just keep on doing that. So on a large project that generally will take 7, 8 years, you're way behind when you start. If you're using the same techniques, the same, not so much techniques, but the same ideas behind the design as you did in the beginning.
Well said. And that's something that we're working on with our students, with our colleagues, is understanding that continuous improvement itself is a process. It's a learning process. And an aspect of that is evaluation.
Definitely. And if someone won't pay for it, then just go do it on your own. And I've had a challenge because the projects I've worked on, the large projects, are far away from me. And with a limited income, it's not an option to just travel there and see how it's working a year or two later. But I'm still determined to go back to some of those places in the future. And every time you're close by a place, even if it's something that you have not designed, but maybe you know something about the design or the space, go and ask if you can see how it works. You need to have some connections because someone just walking into the facility and say, I want to see your design is not going to get you very far in healthcare. But by making connections, by going back and finding those people who had a part in the design, you can tour a space or you can at least talk to people who work in the space and see how they use it and if it accomplished what they intended.
And that's a testament to your passion, Marjorie, not only for evidence-based design, but also making it congruent to the needs of the community as well as for your future practice. I really appreciate that, and I know that our listeners will as well.
Thank you.
Before we conclude our episode, a couple points to consider when listening to Marjorie's perspective and her insights. That the nursing workforce has become more diversified in where nurses are working than ever before. But recent studies have come out showing that we have less nurses attending nursing school. We had a drop in enrollment, ending a 20-year streak of growth. Can design help us reinvigorate the nursing profession? These are the voices that need to be included. Give nurses a chance to be participatory, all nurses. Diverse voices. Help them build the environments that they spend their days in so that they can help us on our worst of days when we are sometimes seeking the most critical of care. This is Elizabeth Johnson for Designing Care and Air. We'll see you next time.